So Thomas Later, who has first started the use of fluids during the cholera epidemic in London, in the suburbs of London, had noted that this is something which is not only making the patients well and comfortable, but it is causing benefit almost instantaneously. So that instantaneously was the catchword, and that was picked up everywhere. And that is why fluids became a common choice. If we look into some of the studies which we have looked upon, the practice of fluid resuscitation across the globe, we find that in 2007 study, they have found that the most common reason given for administering resuscitation fluid was impaired tissue perfusion or low measured cardiac output, and that was for around 44% of fluid resuscitation episodes. Note that it was till 2007, published in 2010. And when the same survey was repeated in 2014, impaired tissue perfusion or low measured cardiac output was the indication in 61% of fluid resuscitation episodes. So tremendously, fluid resuscitation meant a very big thing, particularly after the reverse study came in 2001. And people were very much aggressive towards the fluid therapy. And it was seen that low blood pressure, low urine output, and the low CVP were the most common triggers for administering resuscitation fluid in sick patients. Now, but it is not true that it was only till the fallacy was realized years later, when the newer studies came that looked upon some of the aspects of fluids which was not looked upon in detail in the original reverse trial. And it was realized that the fluids are in fact drugs, and they're no less than the drugs as far as their benefits and the toxicities are concerned. And it was commonplace to take antibiotics as a prototype of the drugs and to compare the performance of antibiotics against the fluids on certain set norms that regulate the drug for its benefit and efficacy. So if we look into the antibiotics, we know very well that inappropriate therapy leads to more organ failure, leads to longer ICU length of stay, longer hospital length of stay, longer mechanical ventilation. And likewise, administration of inappropriate amount of fluids is also linked to the development of hyperchloremic metabolic acidosis, more acute kidney injury, more RRT, and a greater mortality. It is also seen that in antibiotics, if we combine the antibiotics to give a synergistic effect, it is possibly beneficial because we can cover a much broader spectrum, avoid emergence of resistance, it can reduce the risk of toxicities and so. Similarly, with fluids also, these possible benefits have been observed, that specific fluids for different indications and the chances of toxicities due to the individual kind of fluids can be reduced. So whenever we administer such a fluid whose strong ion difference is less than the strong ion difference of the plasma, then that fluid is likely to cause acidosis. Whenever we administer a fluid whose strong ion difference is more than that of plasma, that is likely to cause alkalosis. So this is a rule of thumb. Not only that, the ions are also important to understand wide anion gap and between normal anion gap acidosis, because this is also very closely related with hyperchloremia. So only when we know about the unmeasured anions, so that gives us an indication of how much correction is required in terms of acid-base equilibrium. So we have to be important that whenever we are choosing the fluid, how much the composition of the fluid in question matches the composition of the compartment for which it is meant for. Whenever we are giving a resuscitation fluid or replacement fluid, we are particularly concerned with the extracellular compartment. And therefore, the extracellular fluid, you have to look for the osmolality, look for the other ions concentration and see how much they match. In this regard, normal saline is not a physiological, it is neither normal because the osmolality is very high, and number two, and the chloride content is also very high. So when there are definite consequences of administering high amount of normal saline on the extracellular compartment. On the contrary, if you look into the balanced salt solutions, whether lactated ringer or the plasma light, they maintain a reasonable similarity with the osmolality. And if we look into the strong ion difference, we can see that the strong ion difference is much better in comparison to normal saline. In case of lactated lingers, it is around 130 minus 109, 21. In case of plasma light, it is 140 minus 98, that is 42, which is much close to 40 if we consider 40 as the strong ion difference. So they are much less likely to produce either acidosis or alkalosis in whatsoever form, and therefore their administration may not be associated with complications which might be associated with normal saline. However, all said and done, it is also proven, it is still yet to be proven that these balanced salt solutions are superior in terms of long-term outcomes or in achieving the target in terms of cardiac output or stroke volume or anything in that regard. The other important thing is that we have to realize that whenever we administer a hypertonic solution, whether it has gone into excess or not, or it will go into less amount, we know that in that case, it will drag fluid from the intracellular compartment. So we will have to monitor closely for hypervolemia, hypernatremia, and associated respiratory distress if it is hypertonic. In case of isotonic solution, we also have to monitor for hypervolemia, especially in patients who have heart failure or renal failure, because fluid will tend to accumulate in greater proportion in those patients. But the water is going both inside, that is entering the cells from the extracellular fluid and from the extracellular fluid to the cells against the established gradient that is achieved. If we administer hypotonic solution, then we have to monitor closely for hypovolemia, hypotension, confusion, because fluid will shift into the intracellular space from the extracellular compartment. So depending upon the type of the nature of the fluid, the tonicity of the fluid, osmolality of the fluid, the symptoms would differ, and it is important to monitor those symptoms or look into those signs which are specific for those changes to understand or to prevent from overload. Whenever we talk about about fluid administration, we have to remember that it has been clearly shown that it is the cumulative fluid balance which has been shown to be the most important determinant of benefit or harm. If it is maintained, if it is good, the cumulative fluid balance is to the minimum, the hemodynamic stability, achievement of the hemodynamic stability. In that case, the response or the outcome has been the best. Where the cumulative fluid has been more, then the outcome has been worse. So the cumulative fluid. So in order to do this, this is the way this concept which is prevailing now. It is called the ROSE concept. Some people also say SOSD, but it doesn't matter. It is the same. ROSE concept is named by Manu Malbrain, our very good friend. His book is also getting published this year on the fluids very soon, within a month. And ROSE is resuscitation, optimization, stabilization, and de-escalation. So, and evacuation. So in the SOSD, this resuscitation is called salvage and de-escalation is called evacuation. Optimization and stabilization. So it's just a play of words. Otherwise, the strategy is the same. What means to say that when the patient in the early hemodynamically unstable patient in a circulatory shock comes, the therapeutic goal is to assess and treat the cause of instability. Then the hemodynamic and other targets should be maintained for an adult, which is usually 60 to 65 millimeter of MAP. In normal situation, we are not considering the abnormal situations. And then to give fluid therapy, isotonic crystalloid, 0.5, that is 500 ml aliquots, consider for 4 to 5% albumin for sepsis if the patient remains unstable, RBCs, blood products if patient is bleeding. So depending on that, whatever, and if there is a requirement of any additional treatment, we will have to start inotrope. So you will remember that earlier we used to give more fluids. Nowadays, it is recommended that we have to start inotrope early. But also one has to remember that a patient after getting early inotrope may attain hemodynamic stability, but yet may remain hypovolemic. So he is still in shock. This is particularly true in sepsis, where there is a lot of vasodilatation. And this form of shock is also called cryptic shock. And therefore, it is important to identify cryptic shock by looking into the various other parameters and administer fluids, despite this patients being hemodynamically stable after being administered on inotropes or vasopressors. So first phase is the salvage or the rescue. Next is the optimization, where the therapeutic goal is to improve the global perfusion, because ultimately what matters is the DO2. So once the delivery of oxygen is DO2 is achieved, the organ perfusion improves, the peripheral color and temperature, mentation, everything improves. And then we consider the MAP target, the cardiac index, urine output, and also look into the lactate levels, whether they are not rising or they are stable. Then we decide upon further isotonic crystalloid if it is needed, based upon individualizing the patients on a case-to-case basis. And we also, about additional treatments, we decide whether to continue the inotropes or the vasopressor support, etc. The third phase is the stabilization, which is similar, where the therapeutic goal and the hemodynamic targets are similar to that of stabilization. And here we adopt a more restrictive approach, like no maintenance fluid or blood products, just to ensure that we don't commit and administer erroneously high amount of fluids, leading to fluid overload or excessive cumulative fluid. Here also, if additional treatments are written, then organ support should be started as needed. We can start enteral feeding unless this is contraindicated, and adopt restrictive approach as regards oxygen and all. And the fourth phase, which is very important, is the de-escalation, where maintain the parameters achieved during stabilization while reducing the support, normalize according to patient's age and status, and always fluid therapy you try to give via the food and drugs only. Try to obtain negative fluid balance via spontaneous or diuretic-induced diuresis or ultrafiltration, because here there is too much of volume and we will have to de-resuscitate them so that the organ functions normally. So it is very important to categorize the patient or to fix upon an individual basis that when to start fluids, how much to start, or if the patient is hypervolemic, then when to remove and how much to remove. Now, therefore, I will start with some of the case scenarios. Suppose a 60-year-old man with hypertension, diabetes, CAD, CKD presents with 1 week history of fever, shortness of breath, chest pain, cough, fatigability, and looking distressed on examination, having a heart rate of 110, SpO2 of 86% on room air, blood pressure of 87/45. There are no audible crackles or gallop rhythm, but bilateral pithic edema is noted, so which is indicating that there may be some problem with the. So what fluid should be administered? Whenever such patients are there, we will have to understand that in which portion of this Frank-Starling curve is the patient placed, depending upon, and because only when the patient is on the steep part of the curve, the patient will respond to fluids. If the patient is on the flat part of the curve, then the maximum capacity to produce stroke volume has already been achieved, and it is like flogging a tired horse. So patient has to see that the patient's response to fluid administration, if they're in the ascending portion or not, and that can be assessed by doing a fluid responsive test. So a fluid responsive test is very important in assessment of such patients, and in fact, in all patients, wherever we know, and particularly in them where too much of fluids can be harmful. So how to do that fluid responsiveness test? Well, there are various ways of doing, but it is important to know that it is difficult to predict the fluid status or the fluid response solely from physical examination. This is one which is commonly asked in the exam, the passive leg raising test. So passive leg raising test, in which it is an auto transfusion, because around 300 to 500 ml of intravascular volume from the lower limb drains into the heart once the patient's legs are raised from 0° to 45°. So a pre-post assessment of stroke volume within 30 to 90 seconds from this passive leg raising can be done to measure the difference, where a change of 10% is considered to be responsive. So if the change of 10%, but remember that it is for spontaneously breathing patients, it is not validated for mechanically ventilated patients, but it is very easy. It can be performed in all settings in spontaneously breathing patients. Sometimes it is difficult if a patient is pregnant, if a patient is with abdominal compartment syndrome or certain other conditions where the abdomen is excessively, it is difficult to look for. But in that case, we will also, there are other ways of looking into it, is to look for the echocardiography. Now, the sensitivity of passive leg raising is around 77 to 100%. It is a bit wide, because so that itself shows that the expertise matters, but the specificity is also high. So passive leg raising is one of the very easy, important, and useful ways of assessing the fluid responsiveness. Now, as I told that if we can measure the cardiac output directly by doing an echo, by looking into the echo, we will be able to assess that by doing that, how much of actual increase has occurred. And for that, we know that there is something called velocity time integral. So we do it on when we do a 2D echo, we multiply the LVOT area, which you can see, that is the area marked in blue between the aortic annulus, and we multiply with the velocity time integral to determine the stroke volume. And as we know that stroke volume into heart rate is cardiac output. So if after a positive leg raise, the cardiac output variation of greater than 14%, then this patient is fluid responsive. If it is less than 10%, they are associated with high negative predictive value. Between 10 to 14%, it is doubtful. It cannot be commented upon. Now, other important ways is to measure that we used to do earlier, around 3-4 years back. We used to see the IVC. It is very easy. Everyone can use a sonography using the curvilinear probe just below the sternal angle. One can place it and then turn slightly left. So this collapsibility of the IVC is important. It measures something called the Caval index, or the collapsibility index, which is the difference between the maximal vessel diameter minus minimal vessel diameter divided by maximal vessel diameter. It has been demonstrated that venous collapsibility may be inversely proportional to a CVP. A 1 millimeter change in central venous pressure correlates to around 3.3% change in the IVC collapsibility. So IVC collapsibility less than 1.5, collapsibility index 100%, CVP 0 to 5, we clearly can assign a patient is volume depleted and is responsive. If it is more than 2.5, the collapsibility index 0, CVP more than 20, it is definitely volume overload. So these patients will require de-resuscitation. In between, if it is between 1.5 to 2.5 or 1.5 with more than 50%, then it is, and with a CVP of less than 10, then it is likely to be fluid responsive, but cannot be stated with surety, and the vice versa. So sole interpretation of in IVC for volume assessment was found to poorly correlate and should not, and this should be used in conjunction with other measures and integrated on patient presentation. So this is again another method. Then we have something called the tidal volume challenge. Again, it came from our India only. So if we can increase transiently the tidal volume from 6 ml per kg predicted body weight, you will have not the body weight, you will have to calculate the predicted body weight, to 8 ml per kg predicted body weight for 1 minute, and observe the change in the variation, in the pulse pressure variation. And we see that from baseline to that after 8 ml kg, if it is more than 3.5%, then after tidal volume challenge, then these patients are more likely to be fluid responsive. Now, this is again true for mechanically ventilated patients, not for spontaneously breathing patients. For others, we can have this is called the VEXUS, by which we look into a normal hepatic vein Doppler and we look into the waveform. Normally, we see this systolic A is below, it is greater than diastolic. But in case of mild hepatic vein abnormality, this is less than diastolic. And in severe hepatic vein abnormality, there is reversal of S. So waveform velocity of the hepatic vein is reversed with higher velocities, and this is diastolic states of volume overload. So this can be seen, this retrograde flow can be seen in severe volume overload. So pulsed wave Doppler, this is 2 to 4 centimeter from where the hepatic vein drains into the IVC. Those who have done will know that we change it in the M mode, look into the S and D form and try to figure out whether there is any change in the position of S and D. Now we can look it into the portal vein also, because flow through the portal vein is normally monophasic, but in presence of hypervolumia, there will be pulsatility, and this can be quantified using a pulsatility index. And if this pulsatility index is more than 50%, that indicates severe volume overload. This can also be looked into the renal vein, because with increasing venous congestion, there is decrease in the systolic component of the wave in the renal vein. Again, we have to go to the M mode and see. And with severe renal congestion, there is complete absence of systolic flow, and there will be only during the diastolic phase. But what is important is remember that hepatic vein flow mainly reflects the right atrial filling pressure or the filling pattern. Portal and intravenous Doppler, they will provide additional information about the right atrial filling pressure and its correlation with the congestive organ injury. So this is called VEXUS, and this is also a very important or a useful means to know the volume overload. Again, lung ultrasound, we all do it. We all know that the presence of B lines, 2 or fewer B lines is considered as normal. If otherwise, then we will have to think that, because whenever there is volume overload, there is risk of pulmonary edema. And if there is pleural effusion, that can be identified by the presence of V sign, where you can see it on the right hand side. There is this V sign. So it can be extension of the vertebral line proximal to the diaphragm. So all of these have varying degrees of sensitivity and specificity, starting from clinical examination, looking for dry oral mucosa has a very good specificity, I should say, around 88%, although sensitivity is not that great. So lung ultrasound carries a good sensitivity and specificity. Carotid blood flow with passive leg raise also carries a very good sensitivity. And we can try to figure out, again, the availability is important. So fluid responsiveness is very important before ascertaining and administering the fluids. Now, coming back to the case, this patient was PLR positive. The ultrasound showed IVC collapsibility more than 50%. So we administered ringer lactate at the rate of 4 ml per kg per 10 to 20 minutes. That is the standard norm. And after 4 hours, we achieve a heart rate of 80, blood pressure of 120/70, saturation of 95% of room air, lactate of 1.1, urine output of 40 ml per hour, and the IVC becomes normal. So that is, the patient has become. What should be the strategy now? So once we know that the resuscitation is over, then it is the optimization. So in optimization phase occurs within hours. So there is ischemia and there is reperfusion. These two things go hand in hand. So if after ischemia comes reperfusion, so one has to be careful to see that how much reperfusion is occurring. So degree of positive balance may be a marker of severity of the phase, but there is also the risk of polycompartment syndrome. Polycompartment syndrome means this fluid which you are administered is particularly getting flooded in one particular. Like if the capillary pressure is low, then this fluid are mainly escaping from instead of going inside, they're collecting into the third space. So this causes polycompartment syndrome. So unstable compensated shock state requiring titrating fluids to achieve the cardiac output. This has to be marked, that has to be optimized, and we have to fix up the targets. But whatever targets we fix, we have to remember that the kidneys are at risk of functional impairment and in cases of positive fluid balance. Therefore, positive fluid balance has to be prevented in all terms during the optimization phase. And there can be this interstitial edema and intra-abdominal hypertension can impair the kidney function. So it is good to not to have. Now, following this optimization comes the administration of maintenance fluid. Now, as I told that in maintenance fluid, we want the fluid to enter the intracellular spaces. So once the fluid enters in the intracellular spaces, we don't give ringer lactate, normal saline or other blend. We try to switch on to 5% dextrose or DNS. So we have to assess while giving maintenance fluid that can the patient meet their fluid needs orally or enterally? So we have to consider the fluid and electrolyte needs. We have to see so that there is no positive fluid balance, there is no peripheral edema, the history of fluid deficit, and prescribe after one modification, we should prescribe glucose 1.2 ml per kg per hour, 0.1 this sodium chloride, and along with them we should add potassium because that is the main intracellular compartment. And thereafter that we have to keep monitoring them, and over a period of time we administer 25 to 30 ml per kg per day of water, 1 millimoles per kg per day of sodium, potassium chloride, 50 to 100 grams per day of glucose. This is a rough estimate, not the actual, but we can modify it based upon the needs of the body. If there is ongoing abnormal fluid and electrolyte losses like vomiting, stroma losses, biliary drainage, we will have to replace them. So replacement in addition to maintenance becomes the norm for such cases, and reassess at least daily, stop IV fluid when no longer required, and aim to switch to oral or enteral as soon as possible. Now let us go back to the case again. So this patient was continued on DNS at the rate of 8 to 10 ml per kg per hour. Oral intake was started, and after 96 hours, that is after 4 days, the BP drops to 100/70, heart rate is 90, saturation and room air is 90%, patient develops peripheral edema, worsening respiratory distress edema. The ultrasound shows IVC is distended, 2D echo shows a fall in the stroke volume. Now, what should be done now? So these are the consequences of fluid overload or fluid accumulation. We know that fluid accumulation at 7 days is the marker, but still by 96 hours or 4 days, the fluid can start accumulating and producing signs and symptoms. So there will be symptoms which are akin to in the CNS. There can be cerebral edema, impaired cognition, etc. In the respiratory, there can be pulmonary edema, pleural effusion, etc., which are responsible for increased work of breathing, respiratory distress. If a patient is on ventilator, that will hinder weaning from mechanical ventilation. Cardiovascular leading rise to increased myocardial edema, myocardial depression, diastolic dysfunction. GI may lead to more of ascites, gut edema, etc. In hepatic congestion, leading to impaired synthetic function. Again, renal interstitial edema, interstitial pressure rising, etc., can lead to acute kidney injury. So all of this can start developing after 96 hours, and at 7 days, it will be the predictor of outcome. So there is no clear or unique definition of this fluid overload. You will have to sense this fluid overload both on the basis of your clinical examination and objective findings on your imaging. And there are definite triggers for each, but always, even if you forget to remove the other triggers, it is important to remove the figures for evacuation or de-escalation. And triggers to stop fluid removal it includes that is mean map of less than 55/45 ppv positive. So you see the pulse pressure variation or stroke volume variation greater than 15%, PLR is positive, etc. So these are the triggers to stop fluid removal, and there are certain triggers to start fluid removal, etc. So both these phases are very important, because only by administering fluids we are not able to correct. It is also too important to de-resuscitate in the later stages if required. So fluid accumulation describes a continuum, and no specific threshold of fluid balance alone can define fluid accumulation across all individuals. So the capacity of individuals to handle fluid will vary, plus their comorbidities will also determine to what extent they can tolerate or how much the kidneys can handle. the excess fluid. A goal to zero to negative fluid balance by day 3, and to keep this humidity as low as possible should be targeted. And if the patient is hemodynamically stable otherwise, so then diuretics or a combination with albumin or renal replacement therapy can be used to mobilize fluids in hemodynamically stable patients with intra-abdominal hypertension and a positive cumulative balance after the acute resuscitation is complete and the inciting issues or the source control have been addressed. This is very important because we know that there are two phases, the flow phase and the ebb phase. The ebb phase is later. So patients who do not transition from ebb phase of shock to the flow phase after the second hit, the first hit is after the patient is hypovolemic, following hemorrhage, following anything. Second is when the patient is actually being transfused, and then patient develops hypervolemia, coagulopathy, etc. Then that is the second hit. So if those patients who do not transition from the ebb phase of shock to the slow phase after the second hit, they develop this global increased permeability syndrome, and in that the fluid toxicity manifests. Let us move into another case to look into the other aspects of fluid administration. A 60-year-old male is brought with polytrauma after motor vehicular accident with impaired consciousness, fractured leg bone, and contusion of the extremities. On examination, patient is having tachycardia, blood pressure is 80/50, saturation is at 92%, GCS is 10, chest CVS appears to be normal, abdomen is normal, hemoglobin is 7, platelet is normal. The ABG shows metabolic acidosis, lactate is 2.5, creat is borderline, it is on the upper side of the normal or maybe 1.4, and sodium potassium. So which fluid should we administer? So suppose we administer normal saline, we should ideally in metabolic acidosis can worsen, but still suppose you administer normal saline at 4 ml per kg per minute, it can be given. There is no harm if other fluids, ringer lactate is not available. We can correct the blood transfusion. After 4 hours, there is hemodynamic improvement. The ultrasound shows IVC collapsibility persistent, but 2D echo shows improving cardiac output. That is, cardiac stroke volume has improved. So when we get a 2D echo, then we should go by the 2D echo finding, and we can ignore the ultrasound because there can be other causes which can nullify the effect. So after 6 hours, the ABG shows worsening metabolic acidosis. So what is the likely cause? The likely cause is hyperchloremia. So as I told before, normal saline contains 154 of sodium and 154 chloride. So there is hyperchloremia. Hyperchloremia can lead to metabolic acidosis. It leads to renal failure because it has been hypothesized to cause renal hypoperfusion AKI by virtue of its renal vascular smooth muscle constriction effect. So this is one of the reasons why normal saline in excess is avoided. And whenever we have to administer there is chloride containing fluids, we have to remember that there can be acidosis or alkalosis on a whole lot of things. This kind of approach is called the Stewart approach, which depends upon the strong ion difference, the ATOT, that is the total albumin, and the plasma contraction. So if we see here, then there are certain factors which is decrease in the strong cations is associated with acidosis, increase in the strong cations is associated with alkalosis, decrease in the strong anions with alkalosis, increase in the strong anions with acidosis, increase in ATOT, increasing UMS. So these are all associated with acidosis. So in hyperchloremia, which is more, if it is iatrogenic, then there will be a fall in the SID. In hypochloremia, there will be an increase in the strong ion difference. So this is something which one can work out, and always remember that strong ion difference is not akin to anion gap. The two things are different. So these are the various adverse events which are related to intravenous therapy with point that is normal saline when compared with balanced crystalloids like ringer lactate. One, metabolic, there can be hyperchloremic acidosis, increased need for buffers to correct acidosis, body water, possible damage to the endothelial glycocalyx. Now we know that the target in sepsis, the hit is the glycocalyx, and even in in this crisis in organ failure, it is the glycocalyx which is involved, because this is where the permeability depends. So the permeability is lost at the level of the glycocalyx, so that fluid and electrolytes can move in and out at ease without any regulation. So there is increased interstitial volume leading to edema. In renal edema and capsular stretch can lead to intrarenal hypertension, renal vasoconstriction, fall in renal blood flow, a fall in the renal glomerular filtration rate are all ensues following long-term treatment with in hyperchloremic acidosis. Likewise, in gastrointestinal, in hematological, also there are changes. In hematological, there is also increased need for blood transfusion. If you look into this, was an original review which was systematic review and meta-analysis, which looked into balanced crystalloid versus saline in critically ill adults. It was published in 2022 in NEJM, included 13 RCTs, more than 35,000 patients, and they found that the relative risk of developing AKI on and of being treated with renal replacement therapy with balanced salt solutions versus saline were 0.96. So therefore, it is very important that the estimated effect of using balanced crystalloids versus saline in critically ill patients ranges from a 9% relative reduction to 1% relative increase in the risk of death, with a high probability that the average effect of using balanced crystalloids is to reduce the mortality. Now, this is a very strong finding, but which observed that there was good amount of heterogeneity within the studies, and you can see that some studies contributed very little. So there were proponents and as well as opponents. The opponents said that this trial included both SMART and SALTED trials, which were unblinded, which were not truly randomized. Although both of them are very well-known trials, we read them, we discuss them, and we mention them. The two highest quality trials, that is the BASICS trial and the PLUS trial, clearly have shown no benefit. So if those trials are eliminated and if new meta-analysis is done, what findings it will reveal, that's what the opponents find out. Another important in cases of, since it was a motor vehicular accident with a GCS of 10, is that which fluid should be administered to lower the intracranial pressure in case the same is raised. So two drugs are there, mannitol versus hypertonic saline. We know that mannitol increases osmolarity by diuresis, and hypertonic saline directly increases the serum osmolarity, and there will be a effect on intracranial pressure is more marked with hypertonic saline, and the effect on blood pressure is more marked with mannitol, and there can be a rebound intracranial pressure increase, hypotension, renal failure, etc. with mannitol, but chances are less with hypertonic saline. However, despite there is no guideline as such, despite the lack of guideline endorsement in adult population, hypertonic saline has become the mainstay of treatment in neurosurgical literature, and that's what is under the practice. And if you see this systematic literature, which review came in 2021, it included 17 studies, around 1,400 patients with traumatic brain injury. 708 were given hypertonic saline, 684 were given mannitol. Hypertonic saline had significantly lower treatment failure, lower ICP after infusion termination, and higher cerebral perfusion pressure after infusion termination in comparison to mannitol. But even then, it is not under any guidelines, and there is no strict that one cannot use mannitol, one can use, but one needs to be more cautious and careful about certain side effects, which one can ignore in presence of with hypertonic saline. Let us go to a third case. A 30-year-old we are looking into the different scenarios. So this is one more scenario which is very essentially one should know. 30-year-old female developed severe respiratory distress at 34 weeks of pregnancy. After resuscitation, an emergency cesarean section was undertaken to deliver the baby. The patient developed PPH with more than 2 liters of estimated blood loss. Following the cesarean section, the patient exhibited uncontrolled. So this means that patient has received blood products during the course of her operation, because she has bled a lot, and she is also continuing with PPH. Now she has a hematocrit of 18%, PT of 106 seconds, INR of 10, APTT of more than 300 seconds, D-dimer of more than 20, FDP of more than 20. So a diagnosis of amniotic fluid embolism is based on our clinical findings and laboratory tests. Resuscitation is started with crystalloids at 4 ml per kg per 10 to 20 minutes. Now, what advanced modality can guide fluid fluid resuscitation or fluid transfusion in this patient? Now, this is again one peculiar, not peculiar, but different kind of situation. We know that if we have this thromboelastography can demonstrate the fibrinogen and the fibrinolysis at the same time. So there are certain features. This is the the dependent development of the initial fibrin clot. This is determined with, you can see the capital R here. So that is called the R. The kinetics of the clot formation are detected by K and the alpha angle. The maximal clot strength is measured by the maximum amplitude, and the percent clot lysis at 30 minutes after maximum amplitude reflects the effect rate of fibrinolysis. So this is because if we see a prolonged R, we give fresh FFP. If we see prolonged K or a alpha, we give fibrinogen. If we see that the maximum amplitude is reduced, then platelets, fibrinogen, or cryoprecipitate. If the lysine production, then we give antifibrinolytics. So this is a very take-guided component therapy is useful in such patients who develop PPH or due to some other or develop amniotic embolism, etc. So commonly used coagulation tests like PT-INR, APTT, platelet count, they can take more than 1 hour to report and provides very little information about fibrinolysis. And this information can be take. So we now have. So let us look into another clinical scenario. A 39-year-old male patient with mixed superficial and deep partial thickness burns following gas cylinder explosion in the kitchen is brought to the emergency. Total burned surface area is around 54% by the rule of 9. BP is 80/50, heart rate is 130, respiratory rate is 26. There are laboratory signs of severe dehydration and hemoconcentration. So how do you calculate the fluid requirement? So we know that there are two formulas. The commonly used one is the Parkland, which implies that 4 ml per kg per percentage in terms of percentage of total body surface area. And in children, it is 3 ml per kg per percent of total body surface area. So that much of crystalloids, half of which is given within the first 8 hours, and the remaining half is given in the remaining time, 16 hours. So that is how we determine and we follow up. But we have to know that there is another formula which is given by Brooks, which includes colloids, and there we give 1.5 ml per kg percentage of burn of crystalloids, and colloids 0.5 ml per kg per percent of total body surface area burn. So if the patient is having 60% burn in a 70 kg person, we have in Parkland formula, we give a lot of crystalloids. In Brook formula, we ending up giving lesser crystalloids and some amount of colloids. But for either formula, half of the total volume has to be administered within first 8 hours and the remaining half over the next 16 hours. So this infusion rate should be adjusted up and down depending upon the responses, because some kind of variation in responses is natural, excessive. So we have to individualize the fluid resuscitation to patient's clinical response, because whenever we administer large volume of crystalloids, there is fluid creep because the capillarity of the increased permeability of the tissue. So some of the fluid escapes. So there is edema. So this causes unnecessarily large amount of fluid creep, which can be reduced to some extent with colloids, because by reducing the colloid oncotic pressure, they tend to hold them back, although they are not able. But if you look into the evidences that when should colloid be administered in burn patients, it is regarded that colloid is best used after 12 to 18 hours as a routine therapy or rescue treatment of fluid creep when patient can be found to have a lot of fluid, bloats up, and the intravascular compartment is comparatively empty. Albumin, if projected 24-hour resuscitation, would exceed 6 ml per kg per percentage of total body surface near the 12-hour mark, and large inflammatory induced gaps between endothelial cells lead to increased permeability with leakage of proteins, and this leak is greatest within the first 8 hours post-burn, but it can persist within the 24 to 48 hours. So which means that it should be given within after 12 to 18 hours, no doubt, but also it makes little sense in administering after 48 hours, once that effect wanes off. So that has reduced the use of colloid because the window is quite narrow. Either before that window or after that period, it makes sense. Let's go into another case. A 40-year-old male presented to the ER with generalized body ache, with high fever. The highest temperature was 39.4 degrees for over 3 days. On examination, GCS is 15. Patient is dehydrated with a heart rate of 106. BP is 100/60. There was no rash or bleeding, but systemic examination reveals right-sided pleural effusion, gallbladder wall edema, and free fluid in the hepatorenal pouch. Dengue serology was positive. Now, what should be the line of fluid management? So plasma leakage during the critical phase in dengue, 48 to 72 hours after febrile defervescence, that provokes the shock, multi-organ dysfunction, unless adequate intravenous fluid is started to correct this hypovolemia. And in patients with dengue, we will have to see that if pulse pressure is less than 20, BP is down, patient is in shock, we will have to evaluate the volume loss in terms of fluid. We can start with crystalloid, 0.9% saline or balanced solution. Closely monitor re-evaluation 1 to 2 hours. Look for the BP pulse, adjust the rate by oral fluids if patient can be fed orally. Follow the hematocrit, follow the urine volume and the urine specific gravity. After 2 hours, the patient's hypotension, pulse pressure, then reconsider switch from crystalloid to colloids, that either FFP, albumin, etc. If there is stage 3, then patient goes into the convalescent stage. Otherwise, if there is persistent shock, we consider invasive monitoring and addition of vasopressor. Now, this slide is difficult to see, but just if you can concentrate and try to see, it contains all the information. When a patient in the dengue is admitted, we will first check whether he can adequate oral fluid intake. If the answer is yes, then this patient falls under group A. In group A, patient is without any warning signs, fully able to tolerate oral fluid. So no. If the answer is no, you have to check the hematocrit. Initiate intravenous isotonic crystalloid at 10 ml per kg per body weight in the first hour. Re-evaluate the patient. Look into the consciousness level, heart rate, pulse, blood pressure, CRT, capillary refill time, very useful. Although the way it is measured by using a glass slide normally and pressing it over the index finger and see how long it takes to refill. But the non-availability of glass slide is also an issue nowadays. It's so it becomes difficult. But if it is possible, it is a very useful test at the bedside. So urine output more than 1 ml per kg per hour, then the improvement is yes. Then you can reduce the drip in a stepwise manner. From 10, you come down to 5 to 7 ml per kg per hour for 2 hours. Again, check the hematocrit and clinical improvement, if there is improvement, etc. Otherwise, you have to increase the isotonic crystalloid and again look for the improvement. So likewise, you will have to see that if the patient is re-evaluate and there is no improvement, we have to reload with 10 ml per kg of isotonic crystalloid, maximum twice. If there is still no improvement, then you should consider it as a severe dengue with shock, and shock or respiratory stress with severe plasma leakage, severe bleeding, severe organ impairment. Then you have to need advanced modalities of treatment. So the crystalloids versus colloids in dengue. Colloids were used for many years as the fluid of choice in dengue to urgently restore blood pressure. But such benefits are not sustained over time. No differences between various fluid regimes, either in terms of clinical outcomes or in terms of severity of fluid overload in 48 to 72 hours. And one of the biggest concerns regarding the use of colloids is its impact of coagulation. We know that all colloids have no impact, albumin has, but it is important to understand. So routine colloid intervention is not indicated in dengue. So my take-home message after this would be that intravenous fluid therapy is one of the most common interventions in acutely ill patients. But despite their widespread use, various fluids for IV administration have entered clinical practice. Some of them are indiscriminately used, some of them are inadvertently used, some of them are used without knowledge at times. So this is the which causes toxicities or fluid administration associated side effects. So we should all know the do's and don'ts of the fluid therapy. And earlier it was called the trawl approach. That is the type of fluid, the rate and volume of administration objectives and limit to safety. Now it is called PATROL approach, that is PA PATROL, that is patient and purpose. So only when these are combined, then fluid can be treated as a drug and all the benefits can be obtained to the maximum, and all the slightest or the least possible side effects can also be avoided. Thank you very much.